This program is brought to you by Emory University.
Our speaker this morning is Dr. Maggie Wang, one of our third-year fellows in the clinical investigator track. Dr. Wang is a native Californian who did her med school at UC Davis and then did her residency at Cedars-Sinai before joining our program a few years ago. As you can see, she's going to talk to us today about dyslipidemia and pregnancy. Take it away, Maggie.
All right. Thank you, Dr. Williams, for that introduction. So, funny story of how I actually stumbled upon this topic. As many of you may know, I was pregnant last year and, accidentally got my lipid panel drawn. And so all my lipids were wacky. And that actually led me to have a little bit scare at some point because I thought I was going to have a heart attack, seeing how high my cholesterol was and all that stuff. And I started looking into literature, and surprisingly, I learned a lot from it. So I'm excited today to kind of talk to you guys all about what normal lipid changes looks like in pregnancy, as well as when to spot dyslipidemia in pregnancy that needs to be treated. And so we'll begin. Oops, is it not advancing now? And so before I start with my talk, I just wanted to say I have no conflict of interest with respect to this presentation and have no financial disclosures to make. And the objective of this talk is, like I said, going to be to understand the normal changes in lipid metabolism that occur during pregnancy, to review the association of dyslipidemia during pregnancy with adverse maternal and fetal outcomes, and 3, to summarize the current treatment options for dyslipidemia during pregnancy. And so to start off with talking about what lipid changes during normal pregnancy looks like. And so in normal pregnancy, there are significant lipid metabolism changes that are essential for fetal growth and development. In the first 2 trimesters, what we see is that lipid metabolism is primarily an anabolic state, and essentially the goal is to prepare to meet the exponential increase in fetal energy needs in later pregnancy. And so we have a increase in insulin sensitivity, which then leads to increased fatty acid synthesis in adipocytes. And this increase in insulin sensitivity also leads to an increased expression of lipoprotein lipase, which I'll review in a little bit for those of you that it's been a while since you thought about lipid metabolism. But the increased expression of a lipoprotein lipase then leads to an increased uptake of fatty acids by fat tissues and muscles. And so here is just a figure just kind of reviewing what lipid metabolism looks like. And so you have both your exogenous and endogenous pathways. Through the exogenous pathways, how we intake, how dietary fat gets absorbed by the intestines, and then it gets kind of compiled into what we call chylomicrons. And so these are lipoproteins that are predominantly carrying triglycerides. These chylomicrons are then travels through the blood to the rest of the body. And for our muscles and as well as fatty tissues, there's an enzyme that sits in the capillaries that line these tissues called lipoprotein lipase. So that's right here. And lipoprotein lipase, for if you remember back to medical school, it's an enzyme that breaks down triglycerides into free fatty acids so that they could be absorbed by fat tissues and muscles to be stored. And then you have also an endogenous pathway where the liver synthesizes a very low density lipoprotein, which again is a lipoprotein that carries predominantly triglycerides. It then circulates around the body and goes to the fat tissues and muscles as well. And then the lipoprotein lipase then also breaks up those triglycerides into free fatty acids to be stored. And so essentially, this is what's happening in the first 2 trimesters in normal pregnancy. However, in the 3rd trimester, we have a shift in lipid metabolism from an anabolic state to a net catabolic state. And so what we end up seeing is that there's increased insulin resistance. This increased insulin resistance leads to a decrease in the lipoprotein lipase activity, as well as an increase in lipolysis. And then we also see a rise in human placental lactogen. So that's a hormone that's secreted by the placenta. This further leads to more insulin resistance as well as increased lipolysis. And then at this time, you also see a peak in estrogen level as well. And that will lead to increased lipogenesis in the liver, as well as increased production of very low density lipoprotein. All of this results in maternal hyperlipidemia. And again, the point of all of this is because you have a growing fetus and you want to kind of shunt energy to meet the energy demands of the fetus. And so in normal pregnancy, it's actually expected that your total cholesterol will increase by 25 to 50%. LDL also increases by usually 30 to 40%, but can be as much as 60%. And then HDL goes up by 25%. And then the thought process behind why HDL also goes up is because it's trying to counteract the I guess the atherogenicity of LDL. And then triglycerides also increase by 2 to 3 folds. And so if you look at this figure over here, these levels actually will peak at delivery, and then it's expected to return to baseline within days to about a month post-delivery. And so while it's normal to expect these lipid changes during pregnancy, the total cholesterol and triglycerides should still never exceed 250 milligrams per deciliter. And so when it does exceed that number, that's what we term as maternal supraphysiological hyperlipidemia. So again, that's defined as a total cholesterol and or triglyceride that exceeds the 95th percentile, which is greater than or equal to 250 milligrams per deciliter. And the reason why it's important to identify when this is happening is because maternal supraphysiological hyperlipidemia has been associated with increased risk of adverse pregnancy outcomes, such as gestational diabetes, hypertensive disorders of pregnancy like preeclampsia, preterm birth, and then also moms that have supraphysiological hyperlipidemia during pregnancy also have a higher risk of future atherosclerotic cardiovascular disease as well. Unfortunately, though, the prevalence of maternal supraphysiologic hyperlipidemia is not well known, given that lipid levels are not routinely checked during pregnancy, since currently there are no guidelines recommending to do so. And this is concerning because, as you may or may not know, but maternal mortality has doubled in the United States over the past 2 decades, with cardiovascular disease being the leading cause of death. So just give you guys some numbers, maternal death, which is defined as mortality during pregnancy or up to a year after delivery, has rose from 12.7 deaths per 100,000 live births to 32.2 deaths per 100,000 live births from 1999 to 2019. And unfortunately, there are disparities when it comes to these outcomes, with mothers who self-identify as Black having the highest mortality rates. And then when you look at the different regions of the United States, the southern states, including Georgia, unfortunately, have the highest maternal deaths across all racial and ethnic groups. And then when you're comparing the maternity death rates in the US to other high income earning countries, the US maternity death rates are actually double the rate for most high income countries. And so all this is concerning, and why it's important to be able to identify dyslipidemia during pregnancy is because, like I said earlier, dyslipidemia during pregnancy is associated with adverse pregnancy outcomes, as well as future atherosclerotic cardiovascular disease later in life. And so all of this is contributing to these higher rates of maternal mortality in the United States. And so what do we do about it? Well, first, I think that we have to first figure out how we could identify when dyslipidemia in pregnancy is happening. Like I said earlier, there are currently no practice guidelines on lipid screening in pregnancy. However, the National Lipid Association does provide some recommendations that you can consider following. So what they recommend is routine lipid screening at the initial OB visit, and then a repeat screening lipid panel at the beginning of the third trimester, even if lipids are normal on the initial testing. And then for high-risk patients, such as patients who have FH or just a history of dyslipidemia, hypertriglyceridemia, patients who are obese or have uncontrolled hypertension or diabetes, those patients require more frequent screening. And so what they recommend for high-risk patients is that you get a lipid panel at the initial visit, and then at the start of the second trimester, and then monthly afterwards, starting at the third trimester. And then regardless of risk, if at any point the total cholesterol or triglyceride levels are greater than 250 milligrams per deciliter, a lipid panel should be measured monthly thereafter. And so this is the maternal supraphysiologic hyperlipidemia that I was talking about earlier. One option, once you identify dyslipidemia in pregnancy, is lifestyle modification. So these, isn't different from any other patient who isn't pregnant. But essentially, we recommend that maintaining a healthy gestational weight gain through both dietary and exercise. So dietary recommendations, like all other patients, we should focus on, eating more vegetables, fruits, whole grains, legumes, lean protein, low-fat dairy, and increased dietary fiber, while limiting added sugar, red meats, fried, and fast foods. And then contraindicate, opposite of what people think about exercise in pregnancy, most women who are pregnant should also be recommended to maintain at least 150 minutes of moderate intensity aerobic activity weekly. And if once they get later in the third trimester, where that gets a little bit difficult, walking and low intensity physical activity should still be encouraged. Now going to the pharmacological options that we have, I wanted to just focus this talk on statins, just because statins are the cornerstone of how we treat dyslipidemia, in general. But interestingly, for statins, which traditionally has been considered a contraindication in pregnancy and breastfeeding, that how we think about statins has now changed a little bit. So in 2012, the FDA actually removed statins from being a Category X drug to encourage shared decision-making in certain high-risk populations, such as those with familial hyperlipidemia or known cardiovascular disease. And the reason why is because there is just a lot of data and literature out there just showing that dyslipidemia in pregnancy leads to poor adverse pregnancy outcomes, as well as increased cardiovascular risk later in life. Initially, the reason why statins was considered a contraindication in pregnancy and breastfeeding was because there were animal studies, early case reports, and early cohort studies suggesting that statins can cause fetal anomalies, such as cardiac malformations, midline central nervous system defects, and limb deficiencies. However, there are many limitations that we have to consider when looking at the earlier studies. For the animal studies, they were primarily performed in rodents, for example, and a lot of times there were significantly higher relatively doses were given to these rodents when you're comparing those doses to the doses that we usually use in humans. Another limitation that we got to consider for case reports is there are small sample sizes and usually there's no control group. And then the major limitation for the earlier cohort studies is that, again, they were small sample sizes, and a lot of times these cohort studies was done retrospectively, and so there was a lot of opportunity for both selection and recall bias. And so for the more recent studies that we have now, it's kind of showing an opposite story of what we thought of how we thought about statins earlier. And so this is one of the more recent cohort studies. This was published in 2015, and this was a retrospective cohort study that utilizes US Medicaid data from the year 2000 to 2007. This study included 1,152 women ages 12 to 55 with completed pregnancy and live-born infants who had filled a prescription for statin during the first trimester of their pregnancy. And so if you look at this table over here, what they ended up finding was that congenital anomalies were more common in women exposed to statins, which we already know. So in the statin exposed group, there was about 6.3% versus in the no statin exposed group, there was, or in the placebo group, there was, or sorry, not placebo, control group, there was 3.6% in terms of the number of congenital malformations that was seen. But and then so when they looked at the unadjusted model, that gave them a relative risk of about 1.79. However, this relative risk actually was attenuated when they adjusted for diabetes alone, and so it went from 1.79 to 1.34. And then when they further adjusted for other confounding variables using a propensity score, that risk was actually no longer present. And so that's interesting because that's very different from the previous cohort studies that we were seeing. And then here is just a breakdown of the different congenital malformations. And this is the unadjusted model. So as you can see, there was we did see more central nervous system malformations and cardiac malformations in the unadjusted model, but then after they did a propensity score stratification, that risk actually was no longer present. And then more recently, there were a couple of randomized controlled trials that came out. And so this one is actually a small pilot, multi-center, double-blinded, placebo-controlled randomized trial of 20 women with singleton pregnancies and at high risks, who were at high risk for preeclampsia. So women between 12 weeks and 17 weeks gestation were assigned to either receiving daily pravastatin 10 milligrams or placebo orally until delivery. And what they found, so their primary outcome for this study was actually to see if, pravastatin can be helpful in preventing preeclampsia. And what they saw was that 4 subjects in the placebo group developed preeclampsia compared to none in the pravastatin group. So that kind of gave a little bit, again, this is a pilot study, so we can't make a huge conclusion, but it was suggesting that maybe pravastatin can be helpful in preventing preeclampsia. But as a secondary outcome, they also looked at the safety profile of using statins in pregnancy in general. And what they found was that when they looked at congenital anomalies, there was no difference between the two groups in the rates of congenital anomalies. Specifically, in the statin group, there was 2 cases. One had hypospadias and one had coarctation of aorta. And then in the placebo group, there was 2 cases as well. One had polydactyly and one had ventriculomegaly. And then also, I didn't put it in this slide, but there was also no maternal or fetal adverse outcomes, including deaths in the study. With that said, I think that actually, let's see. Yep. Oh, and then moving on, we also had a larger randomized controlled trial that came out, and this one was published in Circulation in 2021. So this looked at pravastatin versus placebo in pregnancy and high risk of term preeclampsia. And this was just basically kind of a continuum of this small pilot study, and this Cardiology study was, again, a multi-center, a double-blind, placebo-controlled, randomized control with an intention to treat analysis. And so they actually randomly assigned 1,120 women with singleton pregnancy at high risk for preeclampsia to receiving pravastatin 20 milligrams per day or placebo from 35 to 37 weeks of gestation until delivery or 41 weeks. And so here we have a Kaplan-Meier curve. And as you can see, the 2 curves kind of overlap with each other. What they ended up concluding was that pravastatin women at high risk for term preeclampsia did not reduce the incidence of delivery with preeclampsia. So that's a little different from what we saw in this pilot study. But as a secondary outcome, they also looked at the safety of using Prevacent in pregnancy in general. And what they found was that there was no significant difference in the incidence of congenital anomalies. And so, in fact, the placebo group actually had more cases relative to the Prevacent group. And so because of these more recent studies, this is why the FDA decided to remove statins as a Category X drug and now encourages a shared making decision between the patient and the physician when it comes to patients that have a higher risk for cardiovascular disease, such as those who have a history of familial hyperlipidemia. Now, I just wanted to talk about also some non-statin options that we could consider when it comes to management of dyslipidemia in pregnancy. So we have bile acid sequestrants, which are actually the only lipid lowering medication currently approved for treating dyslipidemia during pregnancy. I think the big issues with these is that sometimes these medications is that sometimes it may not be enough to control the cholesterol. And then the other thing to consider is that they tend to be poorly tolerated due to side effects of constipation, abdominal pain, indigestion, bloating, vomiting, and heartburn, all of which many pregnant women already have. And so these medications can exacerbate those symptoms. Unfortunately, fibrates, Zetia, and niacin are not an option when it comes to treating dyslipidemia in pregnancy. These are classified as Category C drugs due to associations with congenital malformations in animal studies. And there are currently no adequate studies in pregnant women to evaluate the safety of these medications. Similarly, PCSK9 inhibitors also are strongly not recommended in pregnant women just because they have been shown to be associated with higher likelihood of congenital malformations. And then other things to consider are LDL apheresis. So in women who have familial hypercholesterolemia, LDL apheresis has been shown to be highly effective and safe. And so it could be used when you need a large reduction in LDL. Similarly, in patients who have hypertriglyceridemia, plasma exchange or plasmapheresis is also shown to be safe in pregnancy and may be used if needed and available to decrease triglyceride levels that are above 1,000 milligrams per deciliter, or if the mother develops symptoms of pancreatitis and has a level that's greater than 500 milligrams per deciliter. Now, what about breastfeeding? What options are there to treat dyslipidemia during lactation? And so statins in terms of breastfeeding are contraindicated just because of a theoretical risk that it could disrupt neonatal lipid metabolism. And the reason for this is because there has been animal studies that show that statins can transfer into breast milk. However, data on the safety of statins in general use during lactation is lacking. Bile acid sequestrants, like I said earlier, it's the reason why this medication is safe is because it's not systemically absorbed. And since it's not systemically absorbed, it can't be transferred into breast milk. And then Zetia, fibrates, and niacin should be avoided. And there's no studies to show that they're harmful per se, but it's mainly due to a lack of adequate studies in pregnant women, particularly during lactation as well. There's just no adequate studies. And then PCSK9 inhibitors, theoretically, they should be if they do get transferred into breast milk, there should be very low levels of them just because it's a large protein molecule. However, it is recommended that if you do decide to use PCSK9 inhibitors during lactation or breastfeeding, they should be used with caution until more data becomes available. And then bempedoic acid, which I forgot to mention earlier, but it's a 99% plasma bound. It's 90% of it is plasma bound. And so again, the amount transferred into breast milk is also likely very low. However, it's currently not recommended during lactation just because there's lack of adequate studies in pregnant women. And so I guess a big question that people have is, well, given that we have a lot of formulas available, can we just, advise patients who are at high risk for cardiovascular disease or have FH to just skip the breastfeeding in general? But I think it's more complicated than that, because one of the things that you got to remember is that breastfeeding itself can assist in restoring maternal metabolism. Essentially, it mobilizes accumulated fat stores, which then leads to a reduction in triglyceride levels and an increase in HDL levels. And so and then there's also been studies that the duration of lactation has been shown to have an inverse association with subsequent subclinical atherosclerosis as well. And so therefore, the decision of when to stop breastfeeding, to resume lipid-lowering therapies, should be carefully considered, considering the favorable impact it has on lipid profiles and atherosclerosis in general, and should involve a shared decision-making between the physician and patient. And so just some take-home points from this presentation. So first, maternal mortality has doubled in the United States over the past 2 decades, with cardiovascular disease being a leading cause of death. Normal pregnancy is accompanied by lipid metabolism changes essential for fetal growth and development. And in the context of pre-existing cardiovascular risk factors, dyslipidemia during pregnancy can be associated with increased risk for adverse pregnancy outcomes such as gestational diabetes, hypertensive disorders of pregnancy, preterm birth, and as well as lead to adverse cardiovascular events later in life. Management of dyslipidemia during pregnancy is complex, given that there are just in general limited data on the safety of lipid-lowering medications in pregnant women. And so developing an appropriate management plan oftentimes involves a multidisciplinary team, as well as shared decision-making that will require weighing in the patient's ASCVD risk as well as preferences. And so here are my references, and that is it. So I'm open for any questions.
Thank you, Maggie. Very good review. Always good to get some cardio obstetrics, pardon me. And this sort of follows sort of the theme of that is sort of that discipline, which is weighing the maternal, risk to the mom from whatever her underlying cardiovascular condition is versus risk to the fetus and treatments that those entail. I guess my question is, has there been any thought or discussion, anything you came across, if maybe of an approach where since most of the harm to the fetus, we tend to think occurs early in gestation, maybe less aggressive treatment for dyslipidemia early, and then as you get later in pregnancy, when maybe the risk of gestational diabetes and gestational hypertension and preeclampsia obviously increases, maybe having a more aggressive treatment approach then when maybe the fetal harm is maybe somewhat less sort of later in pregnancy.
Yeah, I think that's sort of like what this original randomized controlled trial was trying to get at. And so that's why, different from the pilot studies actually started earlier in like the second trimester, versus this study actually, they started giving the pravastatin between 35 to 37 weeks of gestation. I think that might be why there was no difference in the incidence of congenital anomalies when they were looking at the statin versus placebo group. But however, unfortunately, like they didn't get to see the favorable effect of having them on statins in general, is that preventing like preeclampsia, which is a major cause of maternal mortality. But this was the closest study that I could find when it came to like, what if we, start statins later in the pregnancy course in order to try to, avoid the congenital defects that may arise. But in general, I think that a lot of times people, try to skip the first trimester when there's like all the organs are still developing and such.
Thanks.
Does that answer your question?
Yeah. If I just paid a little closer attention the first time.
No.
All right.
No,
There's a question from the audience. Shannon Walker asking, did trials with pravastatin include women on aspirin in both groups, or was that part of the study?
Oh, I can't remember if it was this. I think this study, I think there. I can't remember was this study or another study, but there was a study. Now that I'm thinking about it, I think it might have been this study that they did include aspirin, or at least some of the women did have aspirin on.
Okay, that's good to know because aspirin's now recommended for anyone with high risk for preeclampsia. And so
Yeah.
I feel like sometimes we don't do a good job of testing how newer drugs would impact outcomes in addition to the current recommendations. So good that they trialed it with aspirin already on board.
Yeah. I believe that this trial did include aspirin when they randomized it. The number of folks who were on aspirin was similar.
Listener number 102147 has their hand up.
I think that's me, Robbie, Stan Sherman. Basically, can you tell us what the OBGYN societies are recommending in terms of follow-up of lipids and treatment, anything? Are they recommending anything besides bile acid sequestrants?
No, there's actually no, I mean, I think they're also in the similar boat as us where there's just no guidelines around this, mainly because there's just not enough studies. Like these two randomized control studies that I had just shown you are pretty much like the best we have so far. But I think a lot of these guidelines it's sort of, we have to have a discussion with the patient and just individually kind of figure out what their risks are and go from there. So, but again, like I said earlier, there's just there's no recommendations on how we should screen. Aside from the bile acid questions, those are the only one that's currently approved for treating dyslipidemia in pregnancy. And then statins is kind of up in the air right now, but I feel like there's kind of a little bit more of a shift towards being okay with statins, especially in patients who are at higher risk for cardiovascular events.
Another question from the audience from Dr. Oguni. At first she says, it was an excellent presentation, Maggie. Then she says, have there been studies looking at applying the prevent calculations in pregnancy, especially when we think about the impact of SDOH on maternal mortality?
I actually don't know the answer to that question, Dr. Oguni. Did you have something to add about that?
No. I was just asking, I think that you made a good point about the worst maternal mortality, especially in minoritized women, Black women especially. And I was wondering, the new Prevent calculator uses I think it's social vulnerability index that uses zip code. And I was just wondering if that has been, like, they've been studying, looking at that in pregnancy and how to, we want to tease out not just race, which, as you know, is a biological risk factor, but the impact of the larger social, political, environment. So I was just curious if you knew.
Yeah, no, I have not stumbled upon that. So, I mean, that sounds like a great research project. So
Thanks again, Maggie, for an excellent review on a topic I'm sure a lot of us did not know a lot about. And appreciate everyone being here this morning, and see everyone soon.
The preceding program is copyrighted by Emory University.